Tommy Johnson is a 10-year-old African-American male that is accompanied by his mother. The patient is being seen today for increased coughing, wheezing, and shortness of breath. He was diagnosed with asthma at age 5, but has lately had an increase in coughing and wheezing, especially at night. The symptoms are worsening as of last week, and the patient is having difficulty sleeping because of it. In addition, every time he plays sports, he must use his rescue inhaler. The symptoms can be described as getting out of breath, trying hard to breathe, wheezing, or getting dizzy. His symptoms are aggravated by exercising and are relieved by staying calm. The patient has tried to warm up before exercise to resolve the problem with minimal success. He also states that he has used his rescue inhaler regularly. Tommy uses an albuterol inhaler that he is instructed to use 2 puffs as needed for wheezing. He has no known medication allergies, but does state that the cold weather exacerbates his asthma symptoms. He does not have any significant past medical history, traumas, hospitalizations, or surgeries. He receives routine dental care, eats a well-balanced diet, and practices safety when riding bikes. He is due for his Tdap, meningococcal, and HP vaccines during this visit. The patient's father has COPD, but his mother is alive and well. The patient attends elementary school and enjoys his neighborhood as well as playing outside. He lives with both of his parents at home and neither smoke cigarettes nor drink alcohol. The patient reports feeling tired when he's out of breath, but denies recent weight change, fatigue, fever, chills, or night sweats. The patient states that when he was 6, he threw up all over the bathroom when he had the flu. The patient denies any delayed skin healing, rashes, bruising, bleeding, skin discoloration, or changes in lesions or moles. The patient does not wear corrective lenses or glasses and denies any visual changes. He denies ear pain, hearing loss, ringing in the ears, or discharge. He denies sinus problems, dysphagia, nosebleeds, nasal discharge, dental disease, hoarseness, or throat pain. He denies HIV status, bruising, a blood transfusion history, night sweats, swollen glands, increased thirst, increased hunger, or cold or heat intolerance. The patient denies any palpitations, orthopnea, or edema. He reports chest tightness when coughing and wheezing, and describes it as a boa constrictor winding around him. The patient denies a history of pneumonia or TB. He denies any abdominal pain, nausea, vomiting, diarrhea, constipation, hepatitis, hemorrhoids, eating disorders, ulcers, or black tarry stool. He denies any urgency, frequency, burning, or change in color of urine. He also denies any back pain, joint swelling, stiffness, fracture history, or osteoporosis. The patient reports feeling dizzy when his asthma is bad, but he has not passed out. He denies any syncope, seizures, transient paralysis, paresthesia, or blackout spells. The patient denies any depression, anxiety, suicidal ideation, or previous diagnosis. He does report increased difficulty sleeping due to his coughing. The patient's vital signs are as follows: temp 37 degrees Celsius, BP 100/70, pulse 88, respirations 30, and 97% on room air. The patient is 68 pounds and 4 feet 8 inches tall. He is a healthy, appearing pediatric male and no acute distress. He is alert and oriented with clear speech. His skin is warm, dry, and intact. His eye and ear exams are unremarkable. His cardiovascular exam is within normal limits with no edema present. Lung auscultation does reveal expiratory wheezing in all lobes bilaterally, but his respiratory rate is even with a symmetrical chest wall rise. He has active bowel sounds and abdomen is soft and non-tender. One differential could be bronchitis due to this patient's history of asthma and environmental irritants. This diagnosis is more unlikely because he does not present with a wet cough or a fever. Another differential could be pneumonia due to this patient's respiratory symptoms. However, bacterial pneumonia is highly unlikely in a wheezing child. A third differential could be cystic fibrosis, which is typically diagnosed at birth but could progress over time. Diagnostic testing done in the office include a CBC with diff, with results still pending, a 12-lead EKG, which was normal, an O2-SAT pulmonary function test, which was 77%, peak expiratory flow rate, which was 160 liters per minute, and urine-specific gravity with a result of 1.015. Due to the findings on both the PFT and PEF, the patient's final diagnosis is moderate persistent asthma. The plan of care for this patient includes medications, non-pharmacological recommendations, education, referrals, and follow-up appointments. To begin, this patient was given 2 puffs of albuterol. After 5 minutes, the PEF was repeated and documented. The patient should continue using his albuterol inhaler and take 2 puffs every 4 to 6 hours as needed for wheezing or dyspnea. An IM injection of steroid was administered with an oral prescription to be continued over the next 2 weeks. He should also start an inhaled corticosteroid aerosol solution to be dosed at 320 micrograms per day. In addition, he should start supplemental home oxygen per nasal cannula at 2 liters per minute. Non-pharmacological recommendations include avoiding triggers, taking vitamin C, maintaining a healthy diet, and continuing exercise. The patient and his mom were educated on his current classification of asthma. They were also educated on what medication will be started, the instructions on the correct use of inhaler, and signs or symptoms that indicate emergency care. Tommy and his mother were provided with an asthma action plan that is acceptable and understandable. In addition, Tommy was encouraged to continue to partake in sports and avoid environmental triggers. We also told his mother to consider an allergy evaluation and a pediatric pulmonary referral for further pulmonary testing. Tommy and his mother were instructed to return to the clinic in 48 hours for evaluation.